Today, we use radiologists and pathologists to identify cancers. There are closed-loop systems that will not need any human input.
Chamath and many entrepreneurs feel that the job of the radiologist is like one big CAPTCHA. Click on all the bicycles or click on all the street signs. Couldn't be farther from the truth. Hi, my name is Dr. Rich Hilsden, and you're watching my channel, Knife Skills. Today, I want to talk about what entrepreneurs don't seem to get and understand about the healthcare system. If you're a fan of my channel, it's unlikely you're also a fan of the All In podcast, but these are 4 entrepreneurs that have really grown a podcast over the last couple of years, talking about new technology developments and new opportunities in the business world to solve big problems in our society. I enjoy it. They have a take on a bunch of different issues, but every time they approach the issue of healthcare, I start to cringe because it's really clear that they don't understand what the needs are in healthcare. And when they imagine a future that's being improved by innovative technology, artificial intelligence, other types of solutions, that they're missing the mark on what we really need to optimize our healthcare system. Let's take a look at this clip where Chamath Palihapitiya talks about radiologists and pathologists being taken over by new AI technology.
Today, we use radiologists and pathologists to identify cancers.
Yep.
There are closed-loop systems. We have one right now that's in front of the FDA. That is a total closed-loop system that will not need any human input. So I don't know what those folks do. Except what I can tell you is that we can get cancer detection basically down to a 0% error rate. That is not possible with human intervention. That is judgment.
So here Chamath is talking about how there is new technology to do the job of the radiologist. And that's going to have a big impact on that white collar job, in particular, radiologists and pathologists, where they look at images. Now, I struggle with this for a number of reasons. First of all, radiologists do so much more than simply looking at an image and saying cancer, no cancer. Chamath and many entrepreneurs feel that the job of the radiologist is like one big CAPTCHA. Click on all the bicycles or click on all the street signs, and that's how you prove you're human. And that's the same type of problems happening with a radiology image. Couldn't be farther from the truth. There certainly is an element of image interpretation, and computers can do image interpretation. We recognize that, but a radiologist does so much more. They incorporate their clinical experience into that interpretation to help understand what best treatment modalities would be appropriate, what types of tests would follow up with that. They would talk to patients and determine whether it's safe to proceed with certain types of investigations. They'll talk with the doctors ordering it to see if that investigation is the appropriate investigation. They do biopsies, they do embolizations, they do procedures. Radiologists do so much more than simply just tagging an image with plus minus cancer, no cancer, or whatever diagnosis they decide to make. The same is true with the pathologist. Again, pathologist is largely image interpretation, but there is the element of what stain is appropriate, what follow-up tests should be done based on this. They discuss the results with other doctors and plan treatments. Now, that's not to say that computer AI can't help leverage those tools. For example, in that podcast, they were talking about how developers can become a 10x developer by having AI tool leverage their skill sets. Well, an AI tool could leverage the skill set of a pathologist and have them do more efficient work. And I think that's likely where it's going to happen rather than taking over this idea of identifying an image versus not. I think it's more of a leverage opportunity. But that being said, when I started medical school nearly 20 years ago, we had AI interpretation of ECGs already. But we were taught at the time that we have to overread that interpretation ourselves, that the computer sometimes gets it wrong. And in my own workflow, I do find that the AI tool, when it identifies a normal ECG, is pretty accurate. So I can look at it and just very quick glance at this ECG to see if they haven't made a big error. And if they correlate, I don't have to do much more than that. So that does leverage my skills to a certain degree. But when it comes to an abnormal ECG, that's where things get interesting, because more often than not, the ECG will label some abnormal pathology on it. And when you incorporate that with the information you have from the patient, the situation by which the ECG was taken, you start to understand that interpretation's incorrect because of the context, which is so important. If you think about a career as a whole, I'm sure that computers over time will completely take over doctors' jobs, as they will lawyers, accountants, mechanics, janitors. Any job that you can imagine will eventually be taken over by computers. In the All In podcast, they talked about another issue which is related. I thought this was kind of interesting. And this is the issue of breast cancer surgery and the error rate associated with that. So let's take a look at this clip and see what Chamath has to say.
The boundary condition for AI to replace a human is where the threshold error rate of that AI is the same or less than the human, right? If you look at very complicated markets, where does regulatory capture rear its ugly head? It's in allowing humans to be error prone, and you can't do anything about it. Take healthcare. If you go into a hospital, there's a certain error rate in every surgery, right? There's a certain error rate in the things that happen. But there's probably a whole bunch of ways in which that entire infrastructure can be made much, much better with AI, right? A robot that does laser-guided precision surgery, characterizing tumors with 100% accuracy, so you always get 100% of the cancer out when you go and get surgeries done. All these things are possible now. And all of a sudden, you take these error rates that can be high as high as 20 or 30%. So for example, breast cancer surgeries, the dirty secret of our healthcare industry is that has a 30% error rate. You know, that can and should go to zero.
I want to talk about this issue of the 30% error rate in breast cancer surgery, like it's some kind of dirty little secret. So what Chamath is referring to is this concept, and probably this paper or a paper similar to it, where it talks about up to a 30% reoperation rate when it comes to breast cancer surgery. Now, what's happening here? Well, in DCIS, a precancerous lesion of the breast, there is up to a 30% reoperation rate in many cases. You may be thinking to yourself, well, if the reoperation rate is 30%, the surgeon probably didn't do the right operation in the first place. Well, that's actually not the case at all. The reason being is that in DCIS, we'll see sometimes some calcifications on the x-rays and that are associated with areas of DCIS, but that is not actually the DCIS itself. And so when we go to do a lumpectomy, we remove the tissue, we x-ray it, radiology will look at it and say, yep, you got all of the calcifications, you're good to go, margins should be clear. But then we take it to the pathologist, and after several weeks and stains and looking under the microscope, you actually find out that, you know what? There was a positive margin, and so you have to go back and re-excise the area. What's going on here is you have two different test modalities. You have a lump of fat being x-rayed, and then you have a pathologist looking at it under a microscope. And so the one test is gonna give you a slightly different detection rate than the other test. Now, it would be great if we could have a pathologist dissecting it and staining it right there, but those things take time. A stain takes time to take in the tissue. And so unless we have new technology that's better at finding that DCIS without the process of a pathologist looking at it, you're going to have an error rate because we simply don't have a tool in place that can tell us where the margin is. It's not because a human is doing a wrong operation. If you did the perfect operation, you would still have a margin rate that was positive. And part of the reason is because we don't want to take the entire breast. You want to do breast conserving surgery. You want to save breast tissue, as you're going to have a chance of leaving stuff behind. These errors that happen, if they're called errors alone, are not human errors. They're errors with the technology that we have. It's an error between radiology tests and pathology tests that are completely independent of humans. And the issue here, and why I find this so frustrating, is that in a lot of these areas, these are the areas that we've already optimized for really well. It's very unusual for a radiologist to miss something that was clinically significant on a CT scan or an X-ray. It happens, but it happens rarely. Where the errors occur are the multiple complex human-to-human interactions. And I know if you're watching this, you know that human interactions are complicated. It's oftentimes the communication between myself and another doctor that can be a problem. One example of a problem that was recently solved was medication errors. You'd have all these medications and the nurse would pull out a tablet and maybe they look similar and you grab the wrong one and you give it to the wrong patient. Now we have computers that help us with organization of medications. So you scan the patient, you scan the drug, and you say, okay, this drug belongs to that patient. There are tools that can help deal with those human-to-human interactions. So I do think that there are some opportunities for improvement. And I have some great ideas I think that could be helped by entrepreneurs if they were so inclined to find the areas of big concern in our healthcare system. And I'll list a few of them right here. Number one, let's have a tool that can figure out what medications a patient's on. We spend an enormous amount of time searching around for collateral information to prove that this person's on a particular medication at a particular time so they don't get a medication error. Number two, how about a tool that would help keep an accurate medical history? We ask the patient what past surgeries or medications they've been on or have, and they answer incorrectly all of the time. It'd be great if we had a tool that could go through the chart and say, hey, these are the surgeries that the patient had, and this is the time they had them, and this is who did them. Number three, an artificial intelligence tool that can figure out the difference between an allergy and a side effect. You have patients who come in and they'll have a list of 20 different allergies. Some people will say they had a rash. Some people will say they felt sleepy, for example. And the reality was they may say, well, I had felt really sleepy after I took morphine. Well, that's actually a normal side effect of taking morphine. And that can be listed then as an allergy. And so a computer that could actually sort out the difference between an allergy and a side effect would be huge. Number four, how about an AI tool that reminds us to follow up on tests that we've previously ordered? If I haven't seen the patient or acted on a test result, how about a tool that says, hey, you ordered that test 2 months ago. It's been back for a month in your inbox. Have you actioned it, for example? Because things do get lost. And number five, this will be the last one that I suggest. How about an AI tool that can prioritize our inboxes by urgency of the result? So if the result is more urgent, it'll be at the top of our list when we're fresh, and I can say, oh, that's something I need to action right away. And then the less critical results go down to the bottom of the list and can be checked off maybe at a later time. A tool that could do that type of simple thing would improve the risk of me not acting on a test result, which is another important potential source of medical error in our system. The problem is these solutions aren't as sexy. They're not as exciting, and people aren't that interested in deploying capital in those areas. And yet those are the areas that are high impact. And this is what frustrates me the most about watching entrepreneurs talk about healthcare. I'm not going to be an entrepreneur. I'm not trained to turn an idea into a marketable product, but I'm someone who sees the problems of this healthcare system day in and day out. We need entrepreneurs. We need good capital allocators. These are important people in our society. We need them to help us out, but we need them to focus on issues rather than spending, billions of dollars on a moonshot stem cell transplant solution to kidney disease. We need someone that can help us day to day improve our communication between each other, help us on the day-to-day frictions when it comes to practicing healthcare. Those are where we need solutions. I'm probably going to make more videos like this where I comment and react to these entrepreneurs because it's an interesting podcast, and I do think sometimes it misses the mark. But if you have any ideas where you think AI could help improve the healthcare system from your experiences, I'd love to see your comments down below. I think this would be a great way to create a discussion, and hopefully someone who has the skills to action these ideas will be watching. My name is Dr. Richard Hilsden. You've been watching my channel, Knife Skills. Thank you, and have a great day.